My name's Parambir, and I'll be talking about protein and exercise in older adults. I'd like this to be as much of a discussion as possible. If you have any questions, concerns, pipe right up, and let's see if we can figure things out together. All right, so I'm going to be talking about a few things that are really of interest to me, and hopefully to you as well. It's the outline isn't a typical outline. It's more of a circular process where I'll be talking about nutrition, public health, and exercise, and going back and forth between these three topics. And the reason I want to talk about these three topics is this image right here. When we see this, what does everybody, what are some of the things that come to your mind?
Old.
All right.
Defrosted.
Yep.
Fragility.
Yep.
Fatigue.
You see fatigue, some muscle loss, perhaps. Looks like someone who's got an unsteady gait, that they're almost using those attachments onto her front and back in order to equalize where her center of gravity is. It looks like there is vertebral height loss, stooped position. You wonder about her visual acuity, since that big hat, which probably protects from the sun, also doesn't really let much in terms of peripheral vision or hearing. We see someone who, without knowing exactly what or why, we can pinpoint right away that this person looks to us with this gestalt term of frail. And frailty is something that really interests me. It's something that I think most people within the world of geriatrics get really concerned about, because it's that one underwriting feature which is common to a whole bunch of medical conditions and impacts all of them without really announcing itself. To me, it's sort of that silent underpinner towards a lot of what happens within healthcare in terms of losing independence, of being institutionalized. There's this common theme of frailty. And so from my public health, when my public health turban is on, we're thinking, how can we really battle frailty?
One thing, like, I notice this person is thin.
Yes.
So she is not, I just assume that she is not obese, so she can eliminate a lot of the health problem issues, heart and diabetes probably.
I'm glad you brought that point up. A lot of our studies on ideal body weight are done for people in their middle age group. Let's say we're talking about people between the age of 20 to 60. As you get older, it's actually better to have a little bit more along your waist. You don't want to be in that obese category, but is everyone here familiar with body mass index? So ideally 18 to 25 is what they say. If you look at individuals that are centenarians, they're often not in the lower portion of that 18 to 25. They're in the 23 to 27 category. Having a few extra pounds is sort of like having a little bit in your bank account, so that if you do get unwell, if you do fall sick, you've got something in terms of reserve so that you can fight off that illness. So you're right, we don't want to be obese, but we also don't want to be too thin. And I would say with this lady here, I think she's a little bit too thin. So why does this matter? We're talking about the public health initiative concerns. We're talking about her own independence and safety. With every physician I meet, I can almost, and every patient I meet, a common theme is that our goal is to keep that patient at home for as long as possible. If we can accomplish that, I think we've done something good. And so that's an underlying theme, and I know whenever I hear Dr. Sinha talking, that's the first thing he says as well. And I like that idea. Let's try to keep the patient at home as long as possible. So right now, these numbers are actually about a year and a half late, but approximately right now, there's about 2,000 Ontarians waiting for long-term care. 50% of those patients are in hospital. Some broad numbers for hospital-based care that most people are probably familiar with. A day in hospital, about $1,000. And it does differ if you're in ICU versus if you're in complex continuing care. A day in long-term care, approximately $130. And a day of home care, about $50. That's a 20 times differential between the two, between home care and hospital. So we're spending, if we could move, and I know we can't, but if we can move those 2,000 patients from home and hospital into long-term care, some would say there's a savings of almost $1.5 million there. That's substantial per day. But home care isn't the final solution. I think it's a temporizing measure. I think it's a good measure for us right now. But I'm going to get into something that I think is a little bit better. So all of this sounds scary. And then, unfortunately, it could get worse. So I love these old movie posters, and I threw this in here because I just find it hilarious. A tidal wave of terror. It almost sounds like what we're hearing about for the Great Tsunami. But that's not what we're going to talk about today. We are going to talk about baby boomers because one of the first books that really had an impact on me when I was growing up was Boom, Bust, and Echo by David L. Foote, a University of Toronto professor. And something that, a little quote from that book that really stuck in my head was that 2/3 of everything is explained by demographics. And so I think all of us are fully aware of this, and part of the reason why we're so passionate about the topic today. We're at that we're just past that third category right now. About 2 years ago, there was the first wave of baby boomers that were really turning 65, and at that point, last year, I think on August, whatever, there was a day where they said that from this day forward, for the next 5 years, there's going to be 1,000 baby boomers turning 65 every day. And that's only going to increase. We haven't hit the peak yet. In terms of numbers, the Conference Board of Ontario estimates that the need for long-term care beds is going to rise from a current 112,000 to about 238,000 by 2031. That's a substantial increase if we stay with the path that we're on right now. And there's a lot of talk and a lot of discussion about how to change that trajectory. So I often get the impression that in Ontario we would rather discuss an alien invasion than the long-term care. That's my personal belief. But I love this poster because it's from 1982. And back in 1982, in the American Journal of Public Health, they had this sort of seminal study saying these are the 5 key predictors of institutionalization. And they found that they looked at about 16 different variables and tried to say out of those groups, out of that group, which ones would be the key predictors. And they found living alone, advanced age, requiring assistance with your independent activities of daily life. So that's things like shopping, housekeeping, counting, food preparation, transportation, things like that. Requiring a mobility aid, and also mental disorientation. I think, again, intuitively that makes sense. 30 some odd years later, that all holds true just as much today as it did back then. So going back to our patient right at the beginning, where can we see the scale? Are people familiar with this? So this came out of Dalhousie University. It was produced by Dr. Watford. He's a geriatrician and gerontologist who wanted to create a really simple way to sort of quantify frailty. And originally came up with, I think it was an 87-point scale, and you would answer yes, no, and try to quantify a bunch of different measures, and he would grade your level of frailty. But I don't know too many clinicians that would spend the time to answer 87 questions, and so he knows that most physicians are relatively simple and time-pressed, and so he created a picture chart. And I like this, because I can look at the patient, look at the chart, and point to where I think that patient falls. And I use this as a means to track changes over time. What we need to do is patients that are at the, I would say, levels 7, 8, or 9, those are patients that are almost always going to be institutionalized, and they're past the point that we're going to be able to likely change that trajectory. And so it's moving our direction towards levels 4, 5, and 6, vulnerable, mildly frail, or moderately frail. And that's where most baby boomers will find themselves within the next 10 to 15 years. One of those 3 categories, and if we can make a change in one of those 3 things, we can actually change the entire equation of how many long-term care beds we need, what the overall cost of the system will be, what the quality of life impact will be. That's the golden juice. That's what we're going after. Where would you place Our Lady?
7.
severely frail? I can see her getting there very quickly.
Yeah, let's say 4.
I would say probably 5 or 6.
Yeah, I
Looking
think
at the assistive devices, she's on her own, so like she's not using a cane or a walker, so she could 3 or 4.
I would tend to put her around 4. I'd say she's she's a vulnerable person. She's managing right now, but she's at a point where one illness, a bout of pneumonia, could tip her over the other end. She spends a week in hospital, and I don't think that person would be the same going in as coming out. She has a fall where not a hip fracture, but let's say a Cole's fracture. Let's say something else happens. And I can see her falling very quickly, or going down a slope that we wouldn't want. So that's the type of individual that we really need to be targeting our efforts towards, and someone just a little bit before her stage. So we've heard this term, sarcopenia. It's from the Greek word which means poverty of flesh, and I like that. Very an apt term. It's a progressive decline in muscle mass from approximately 3 to 8% per decade. Not everyone will get sarcopenic. A certain portion will start in their 30s, about 30% will have it by their 50s, and about 50% by the age of 80. That mimics quite closely, especially in the older age group, the numbers that will get dementia as well. Is there a correlation? There is. Is it a causation? No. So what can we do? Sarcopenia, to me, mimics many of the, is a great bellwether, or the canary that's sort of mimicking frailty. And now frailty is a broad term, but sarcopenia is something I can go after. And when I try to go after it, what do I choose? And there's a lot of debate within the literature as to whether or not sarcopenia is caused by a lack of protein either not being ingested or not being available to the cells once it is ingested. And those are two very different questions. Or on the flip side, is it due to intrinsic or extrinsic factors that limit a person's ability to participate in activity? Is it that they are in an environment where they can't participate in activity, it's not safe for them to be active? Or is it that they've got arthritis or a lack of social supports that prevent something from them actually exercising? And so there's a group of physicians or a group of scientists and academics that look at it from a protein perspective, and a group that look at it from an exercise perspective, and I want to sort of cover both through this talk. I call it the ultimate showdown. So above and beyond sarcopenia, there's anorexia of aging. And this can lead towards sarcopenia, but it doesn't have to. Not most seniors aren't sarcopenic. Many of them, however, do have anorexia of aging. What does that entail? A decreased desire for food, and hence decreased caloric intake. I'm just not feeling hungry. That's a common response. Why? Some people feel that's because there's a lack of social stimuli. There's a lack of enjoyment of their food. They don't get the same sense of smell, same sensory reception that they would have from their food. There is a lack of desire for food, both in terms of drive for thirst, and that in terms of the pathophysiology of it, they're just not producing as much ghrelin and leptin that actually entice our bodies to want to eat something. Yep.
I'm also, and I know in my case, I try not to eat too much because I don't want to gain weight. So it's not for any of those reasons.
Yeah, so I would say those are social factors. I would say that would fall into wanting to maintain body image in a certain form and worrying about changes. And so going back to one of our other colleagues' comments about wanting to make sure that you don't fall into a trap where you're gaining weight and becoming obese. That's a very reasonable reason to limit food intake.
Does that mean this person is undernourished?
Not necessarily. Malnourished doesn't necessarily mean, so once you become sarcopenic, malnourishment can fall into that. Sarcopenia looks specifically at muscle mass. You can have a decrease in muscle mass, but you still have all the nutrients that you need to survive. When I think of malnourishment, I'm looking at someone who's really not getting the basic essential amino acids, vitamins, minerals that they need. And so is there overlap between those two terms? Definitely. The people that come from the protein perspective would say that sarcopenia develops simply because you're not getting enough protein, and so that's malnourishment in that form. But the exercise group would say no, they're getting the protein, their body's getting their nutrients, they're just not using it. So there is some overlap if you looked at it as a Venn diagram. One of the things that comes out throughout all of the literature, both from the exercise and the protein group, is that your minimum daily needs aren't likely going to be your optimum daily needs. And so think about that as we go through. In terms of protein, most people have heard, and this has been a great body of evidence over the last 5 to 10 years, about the golden window, or the window of opportunity after performing some exercise to ingest some protein. And so this group wanted to look at seniors and say, how does that window of opportunity change if you're an older athlete or an older individual in general? And let's say you have a bout of exercise. What is the anabolic response after that exercise? In younger people, we see that they sort of peak within that 1 to 3 hour category. And so often the exercise nutritionist will say, make sure you try to get some protein and carbs within about 30 to 60 minutes after your exercise. Within older individuals, not simply older athletes, their peak doesn't happen until about 3 to 6 hours. And so that's useful to us. We can use that. We have a longer area or a longer window to operate within. But we also know that if we compare older and younger athletes or individuals, there's a certain window that they need to hit in terms of protein consumption in order to spur that anabolic drive. And so for a younger individual, if they were to ingest, let's say, 16 or 18 grams of protein, they will have spurred on their anabolic drive to its fullest extent. With an older person, often that's not the case, and it can be because of a lack of ingestion of the protein, so the body just doesn't absorb it as efficiently. And also, once it's inside the body, it needs more in order to start that engine revving. And what I'm trying to bring home here is that making sure you get protein throughout the day is important. You have that large window, but you want to make sure that you hit a certain quantity or figure in order to spur on the anabolic drive. And so what we find is that if someone says, I ate tea and toast for breakfast, and then a soup and a slice of toast for lunch, but for dinner I had a piece of salmon and some vegetables, their total consumption or daily needs for protein would likely be met if you're looking at it from a very sort of yes-no perspective. They might have gone a total of, let's say, 60 grams of protein. But because most of that protein came in the evening, they weren't meeting the minimum that they required in order to spike the anabolic drive throughout the day. And so they were actually in a catabolic state for most of the day, and then when they hit their needs, they actually exceeded it, weren't using that extra protein, and so it was sort of a waste. A better way to sort of approach this would be to distribute your protein throughout the day. And this was the finding of it was a fun paper. It was in the Current Opinions in Clinical Nutrition and Metabolic Care. And there's been more on this since then. This was back in 2009. What else does a high protein diet do? And I've got references for all of this. There was an article in Neurology showing that a diet high in protein, and they considered high in protein an average of 85 grams, was correlated with a decreased stroke risk. When you work out those numbers on a population basis, they estimated for the US, if every senior citizen was hitting that magic number of 85, they would have 1.5 million fewer strokes.
Why?
They don't know.
They don't have any thoughts about why?
Lots of thoughts, no answers.
That's the problem with medicine.
Yes.
Yeah.
There's thoughts too. I'll talk about this a little bit later, but there's protein does something in your body here. So protein drives something called insulin-like growth factor. And so perhaps the remodeling stage is a little bit different. Perhaps the buildup is a little bit stronger. Perhaps people that are eating more protein in their diets are not eating some other foods which are bad for them. Perhaps they're more conscientious of their diet. So there's a whole bunch of factors there that come into play. It's really hard to try to tease them out, but you can say from a very yes-no perspective, it seems like a higher protein intake is associated with a lower stroke risk. You do get that insulin-like growth factor spike. And IGF-1 is one of those hormones that's in the limelight. It's associated with growth hormone. It's often quite high when we're children. And spikes in insulin-like growth factor drives a lot of the anabolic drive within our body. So IGF-1 starts a cascade that creates an anabolic drive within our body, and having a spike in IGF-1 can be quite useful. You can also induce this with aerobic exercise. We know that a high protein diet is associated with increased bone mineral density and also decreased fracture risk. Hold on for that. Controversial topic. So lots of studies looking at fracture risk with protein. When you're going through the literature, some people say yes, some people say no. The challenge of combining studies is that they'll be looking at different areas of the body. Are they looking at decreased risk of fracture within a hip versus vertebral fracture? What's the study size population? How long did they analyze them for? What was the increase in protein? So when I surveyed the literature, I found a study that I liked, the Women's Health Initiative. Most people here have probably heard of it. There was a lot of hoopla about one of their findings about, what was it, 5-6 years ago, maybe longer, with breast cancer and estrogen. And so they've been tearing apart the Women's Health Initiative, or not tearing it apart, looking at different aspects of it. And one of the sub-studies was at fracture risk, and they found that a higher protein intake, so going from 15% of your daily caloric intake of protein up to 35%, was associated with a decreased risk of forearm fracture and increased bone mineral density. No association with hip or vertebral fractures. So there was something there, and it was a large enough study that they could say that this was both clinically and statistically significant. Yep.
I'm just curious, forearm fracture, I'm thinking of fractures occurring as a result of weight bearing, but forearm's a little different. How do you fracture forearm?
The most common is a foosh, fall on outstretched arm.
And then you
Yeah.
got it.
That's the, it's probably the most common fracture that I see. It's up there with hips. Hips are obviously much more detrimental to the patient's overall well-being, but try helping someone who lives alone and now has broken their dominant arm and can't get any sort of support in the community. It's also quite devastating to them. And so if we can say that making a dietary change can help reduce that risk, then I think we're moving in the right direction in one area. Much of the debate around protein and bone mineral density was confused by a third variable. And that third variable turned out to be calcium. Seems intuitive when you look back at it, but at that time, if you look at studies from the mid-90s until mid-2000s, they weren't really quite sure why some people would have a beneficial effect from higher protein levels and others wouldn't. And they found that calcium sort of act as a flag or as a gate, access gate towards the bone mineral density. And what was interesting here is that you needed a certain quantity of calcium in the body in order to maximize the usage of protein in order to apply it towards creating new bone. So protein by itself, we've known probably for over 100 years, if not longer, that if you increase your protein and nothing else, you're going to start actually urinating a lot more calcium. So protein is, there's a system in our body that when we start to get more protein out and we flush that protein, the protein, as it gets broken up within our body, releases a lot of acid, and the body will neutralize that and offset that by releasing some calcium. It creates a feedback loop involving the parathyroid and thyroid glands in order to start absorbing more calcium. So more calcium is needed in our gut. Well, how much do we need in order to make sure that we maximize bone deposition while not having any excess? Because excess calcium causes issues as well. We'll get to that. And that number turns out to be 408 milligrams. Where should our protein come from? There's my opinions on this, and we'll go to the food. Let's stay within the Canadian Food Guide right now. One of the biggest things that they recommend in terms of getting sources of both protein and also calcium is from milk products. Big study out of Sweden, published in the British Medical Journal, that came out only, I think it was 2014, but I think it was in earlier in March or February. It was published online a few months before that. So really new study, good quality, large group. I think it was looking at 10,000 or 12,000 individuals. And what they found here was that so they were looking at mortality, fracture, and milk consumption. And they broke it up into 3 different groups. And they found that people that had low or moderate milk consumption had no increased risk of fracture or death. But the people that were at the higher end, the people that consumed more than 3 glasses of milk per day, were at increased risk of both all-cause mortality and fracture risk. Yeah.
Interesting.
The interesting part to me also was that fermented milk products, things like yogurt, sour milk, cheese, were associated with lower rates of fracture mortality. We don't hear this often from our food guidelines and such, and I find that unfortunate. But this is a relatively new study, so I'm hoping things will change. In the British Medical Journal, a few years back, another big study came out, and most people probably would have heard about this one, talking about calcium supplements. And there was a link between calcium supplements and myocardial infarctions within their study population. And so here what they found was that people who were supplementing, taking not just dietary sources of calcium, but using calcium citrate or magnesium tablets, were at increased risk of MI. Very controversial topic. Again, we're trying to encourage much of the population to be drinking milk. And their conclusion was calcium supplements should be used with caution. Canada Food Guide came back, Osteoporosis Canada came back with still recommending between, looking at depending on the institution you look at, between 1,000 and 1,200 milligrams. I don't know if any of you know, but I don't know where that number comes from. If you look at the evidence in the research, the number that they say is 408, so at least 500 milligrams. And you can easily get that if you drink a glass of milk, have some cheese, eat some almonds, have some spinach, lots of different sources, you're going to easily hit that number. But we recommend supplementing anyone who's getting less than 500, actually less than 1,000, getting them up to that 1,000 level. And unfortunately, I don't find the evidence that supports that recommendation. I'm not the only one. So this was, I want to read this quote to you. The guidelines continue to recommend 3 daily servings of dairy products, despite a lack of evidence that dairy intake protects against bone fractures and probable links to prostate and ovarian cancers. This was before those 2 big studies in the British Medical Journal. This was not some random public health student at some random university, but this was Walter C. Willett, and he is Chair Emeritus of Division of, I think it's Clinical Nutrition at Harvard University. And this was published in the New England Journal of Medicine, and this was done in 2010. So the food guide recommends the new food guides, or the new recommendations come out every 10 years. They've released the 2015 set. They're out for public review right now, and it'll be interesting to see how things change.
I was reading that in other parts of the world that the recommendations are nowhere near as high as here.
No, they're not.
Yeah, there's like a third of it, basically.
So as an aside, I guess, is if you look at Health Canada, if you go to Health Canada's website and you look at how the guidelines are created, they use the Institute of Medicine's numbers. So you go over to the Institute of Medicine. That sounds like a good, knowledgeable group of individuals. And they refer to, so IOM, and the IOM's nutritional department's based out of the Keck Institute in Washington, D.C. So the Keck Institute was started by one of the founders of Standard Oil, part of the ExxonMobil group. They became philanthropists afterwards and donated a lot of money, created the Keck Institute. The current president of the institution is, I forget his name, I think it's Robert Foster. He's the 26th richest man in the U.S. And they have lots of meetings that no one really knows what goes on inside of, and lots of industry sort of support and influence. No one really knows exactly what happens, but our minds tend to wander. And especially when we see the academics and the studies showing one thing and the guidelines recommending another. So I'm not here to point fingers, I'm just sort of here to bring up some evidence and let us make our own conclusions. So, milk isn't the solution for preventing against fractures. So what is then? How can we try to prevent us from having fractures? Well, great evidence exists for these two techniques, which have been around for many hundreds of years, and side effects. There are some. You've got to be careful. Tai Chi is something that the gentleman on your left is doing a traditional pose, and there are issues always there with the potential to fall. The lady on the right is in a yoga pose, and within the two of them, we find that there's a small number of individuals that, with spinal flexion exercises, can cause anterior wedge compression fractures of their spine, but generally well tolerated. You go at a rate that's comfortable for you, and what they're really trying to do is improve gait and posture balance. And those two things are associated with a decreased risk of falls. And that stands up true throughout studies going back a solid 40 years. Since we first started to ask that question, we realized that if we get people to practice how they're standing, to be aware of what they're doing in terms of their body position, they get better at it. So if we do that with them for half an hour, they're better at it for the next 12 and 14, 15 hours that they're awake. And you train them at this for 6 months, and if you come back a few years later, they're still good at it. It's a skill you learn. I like that. Tai Chi and yoga. What else can we do? So if you look at Osteoporosis Canada, great organization in many ways, they recommend weight-bearing aerobic exercises or physical activity. I don't know what the difference between aerobic exercise or physical activity is. I would think that they'd be the same, but not ignoring that. Weight-bearing activities, okay. Their examples are things like walking, jogging, low intensity, just get your body moving. So I decided to ask myself, well, is there good evidence for weight-bearing, low-intensity activities to prevent against bone mineral density loss or reduce risk of fracture? That was my question. When I looked into the literature, I found that there's a lot of studies out there. Some yes, some no. Some big studies, some small studies, and so it becomes a difficult question to ask. And when you've got difficult questions to ask like that, I've grown up, thankfully, in the era of the Cochrane reviews. Has anyone heard of the Cochrane group before? Excellent. Can you tell us a little bit about Cochrane?
Well, I think it's a bit of an offshoot from traditional medicine, and that they have more of a rebellious attitude, more of a questioning attitude to everything.
Partially why I love them.
Yeah, I would love to.
And so what Cochrane does is it says, let's ask questions that are relevant to clinical medicine. Really simple things like, will amoxicillin treat most ear infections? And how many people do I have to treat with an ear infection in order to make one better by giving them amoxicillin? Very simple, straightforward questions. And then they review all of the literature. They ignore the stuff that the industry sponsors, so they'll include it, but they'll make amends. They get the studies that were potentially not published. They'll look into everything and create a massive study. They'll call it a systematic meta-analysis. And these are very, very large projects. They take thousands upon thousands of man hours. Usually there's a team of 5, 10 really smart researchers that are working away at this for weeks, months, or years. And so one of the questions that they want to tackle was the role of exercise in preventing bone mineral density loss or reduced fracture risk in osteoporotic individuals. Okay. So what can we do in terms of exercise to reduce the risk of fractures? And their finding was non-weight bearing, high force exercises such as progressive resistance strength training for the lower limbs. That's what they found to be the best evidence of reducing your risk of fracture. Weight bearing aerobic exercise.
Can you go back one more time?
Yes. So what does that mean exactly?
So great. I scratched my head at that a little bit as well. It's a loaded term, I think. And non-weight bearing, high force exercises, things where, let's say you were on a leg press. Let's say you're doing a squat. Let's say you're doing a lunge. Something where you're using your weight, but you're actually adding on to that weight. Or you've taken your body position off, so you're in a position where you're doing a leg press, and now you're using the machine. Something where it's high force, short duration. That is what a lot of people are starting to realize actually challenges the bone and makes the bone respond by growing stronger.
And that's not weight bearing?
No. When you've got added weight on top of your own, so the person who does a leg press, once you take your weight off the table, so once you've counteracted against gravity, then it's not weight bearing, and that's the leg press example. And if you're doing squats and you've added on an extra 20 pounds, so you're not using your own weight, you're using your weight plus.
I managed to help my bone mass a lot actually by doing squats in my hip, and yeah, it works. It's amazing.
But the lifting weights would be
My
your
back
weight
too,
plus.
actually.
Upper body. So if you're doing a shoulder, let's say a bicep curl, or a shoulder press, a military press, all of those are upper body strengths. They did not correlate with reduced fracture risk in the Cochrane study. Lower muscle groups, particularly, you want to strengthen up the quads. One of the things that I will do whenever I have a patient and I'm worried about risk of falls is check to see how strong their quadriceps are. And quadricep weakness is a proxy for fall risk. And so they say, how do we target those muscles to make them stronger? And the way to do that, just like the way to make your biceps stronger, isn't to use just the weight of the arm itself, it's to add on to that weight. So if we want to make our biceps stronger, we grab a barbell with 5, 10, 50 pounds, depending on how strong you are, and you curl it. Same thing with your legs. You can do leg curls, you can do leg presses, you can do squats, lots of different activities, but you want to target those quads. And the quads are the 4 big muscles at the front of our leg. And we know that in individuals who even have bad arthritis of the knee or ligamental laxity, because the ligaments that control positioning of the knee are weak, if you've got a very strong quadricep muscle, it can counteract or accommodate for those weaknesses in your knee. Yeah.
Would it also be swimming because you'd have resistance from the water, but you'd be non-weight bearing in the water?
Swimming is a great activity. I absolutely love it. Not if you're if your goal is to reduce your risk of fracture, it's not going to be. The evidence for it doesn't exist. Lots of other benefits, well, we'll get to those, but not from this one specific goal.
So cycling, even though it's non-weight bearing, you're exercising your quads, right?
Yeah.
So
Cycling is
that
a
would be a
great,
good
great
thing,
activity. I love it.
Yeah.
Sorry, so when you start putting your weight on it, it doesn't have the same effect. That's what I'm having trouble understanding.
You are using your weight, but you're using your weight plus. And so,
But if you're using your, like if you were to do squats,
Yep.
for example, that's weight bearing, is it not?
Yep.
But if that's a non-weight bearing.
you are. They were looking specifically at a group of individuals that were exercising within a gym and had the ability to do squats. Well, they weren't doing a squat, they were doing a leg press, which mimics that activity, but they were non-weight bearing because they were seated in a 45 position
But
angle.
that's just a position.
Yeah,
So, okay.
but the real,
I think I get the point.
yeah,
Yeah.
the gist of it, the goal was
Yeah.
you got to do things to strengthen up your quads. And you're not going to do that as effectively by just using your normal body weight. What was this? So this was their strongest finding, and this got a lot of press. And so, how strong of a benefit is this? So results suggest a relatively small but statistically significant, possibly important effect of exercise on bone density in postmenopausal women compared with control groups. That was the study population that they were looking at. And what was this magic number that we should be going out and doing these leg presses and other things for? How much bone will we add? Any guesses?
2%?
30?
7.
Oh, 7. 7 to any other?
Is that all?
There's a lot of press over this article. If you read the headlines and then you look at the number. Small, statistically significant, but possibly important. I tend to doubt that. Okay, so if not for bone mineral density, what is exercise good for? Very good studies. I'm particularly impressed by these two researchers. And you've probably heard also that use of typical typical antidepressants, things like SSRIs, are equivalent to getting 30 minutes of exercise. That was their study as well. So this one was looking specifically at cognitive effects in elders who were participating in an exercise program. And they found that the cognitive the mood benefit of participating in an exercise program was equivalent to the mood benefit gained from starting on a antidepressant. That's really good.
Incredible.
Especially if what we're trying to do is get you on as few meds as possible. How much, so what are the big ones right now? Citalopram, or escitalopram, because the drug companies are really pushing that. Any numbers on how much that would cost per month? A prescription of citalopram?
60?
So escitalopram, I believe, is 130. I can give you the exact number in just a second. I should have pulled this up beforehand. I do apologize.
And what is the dosage of exercise that you need?
30
to have
minutes.
The same effect?
30 minutes, and they did it 3 times a week.
Is there a target heart rate or?
They weren't using a target heart rate. They were trying to get people out. It was structured exercise as part of a group learning experience. But so the number for escitalopram per month is about $125, not including dispensing fees. A little bit cheaper to get a Good Life membership. Not that I'm stocked for Good Life or anything else. Again, so cognitive benefits from exercise. And we've shown this in all age groups. There's both from elementary age children all the way up to older adults. And this is going back 30 to 40 years. Good studies since, I think the first study I found was 1982. And not any one specific sport. So we'll notice differences between different sports and different parts of the brain. But if you're looking at overall cognitive benefits, you get that regardless of whether or not you're going for a walk, a jog, if you're cycling, if you're swimming, whatever you're doing, you will improve. Great review article published in Nature Neuroscience by one of the the big honchos within this area of science, Alfred Kramer. And here what we're looking at is we're seeing a control group, and what they did is a stretching exercise, and then the actual study population, and they did some sort of physical activity, the jogging, the cycling, whatever it is, resistance training. And in each group we see that it's a statistically significant improvement in cognitive features across all aspects, all cognitive domains, from executive function, spatial, vocabulary, speed responses, all of them.
Concentration as well?
Yes.
So it's just for a period after you exercise, or does it continue to make you smarter?
There is, so a study came out 2 weeks ago in Lancet looking at, it was a finger trial, it's what it's called, and what they look at is, it was a multi-domain study looking at both diet and exercise, and they did an intervention, I think for 6 months, and then looked at them again a year and a half later, and those positive benefits had lingered. So by making these changes, it's not just a short-term benefit. Many people will actually continue. If you start a person on a home-based exercise program versus a in-hospital exercise program, who do you think is going to continue on that exercise program 6 months later?
Home-based.
Home-based.
Approximately how much? So if you have 5 people, and we start all of them on a home-based exercise program, what number would you expect to still be on that program 6 months later?
65.
Really close, 68% is the number that they say. Fantastic. I think that's great.
Fantastic.
When I start a patient on a medication, how many of them do I expect to A, fill the med, and B, still be on it 6 months later? I don't know, but I guess it's approximately the same number. One of the differences that we know in terms of the type of sport and what happens in your brain is that, and this study initially done in mice, so we don't have conclusive evidence in humans yet, but I'll get to that, is that aerobic exercise spurs on that insulin-like growth factor 1, while resistance exercises, strength training for instance, spurs on what we call brain-derived neurotrophic factors. And these are 2 different approaches towards getting cognitive benefits. So the end goal of improving your cognition as a global improvement, both exercises help with, but they've got a different pathway towards that. And that's important because both of those factors work in the brain in different ways. So if you look at your cognitive domains, things like spatial orientation, short-term memory, vocabulary, they're influenced in different ways depending on the exercise that you're doing. Really great study. It's a fun group out of the University of British Columbia. This paper was authored by Lindsay Nagamatsu, and what they found is that resistive exercises were associated with increases in spatial memory and vocabulary. Yep.
Sorry, I'll just ask this now because I have to scoot, but when you mentioned that, I'm wondering about interval training, because I hear a lot of good things about that.
I'll get to it.
Okay. I'll have to tune in later.
Resistance training was associated with increase in spatial memory. And if you think about that, that's the memory that helps you understand where your body is in orientation to space and what your environment looks like. And so the idea is that you improve your spatial memory, you reduce your risk of falls. That's really good. We have an answer. All we need is to get more exercise. Yeah. Unfortunately, that number is actually 1% lower than the last time they did that survey. It used to be 18%. Now it's only 17% of Canadian adults 55 and older that regularly participate in exercise. A whole bunch of reasons there. It's higher in areas where there's increase in, so socioeconomics play a role inside of it, social supports play a role, a whole bunch of different things. But regardless, at the end of the day, fewer than 1 in 5 Canadian adults are getting the kind of exercise, getting the quantity of exercise that they currently recommend. And this is self-reported, so self-reported is almost always higher than actual numbers.
It's very boring. It's a stimulation.
That's why you should go to a group.
You've got to find the right exercise, something that, yeah.
It's very, very hard to find other seniors. I live in the building downtown. It's full of 30s and 40 years of age.
Good questions that the urban planners need to get more involved in. I think if we're going to design cities for the future, we need to be thinking more about how to incorporate living spaces that bring together people from all age groups and making sure that those spaces are safe and that you've got a common meeting ground that you can meet with other individuals that have like-minded interests. And that doesn't matter if you're 20, 30, or 90, you need to be able to have those spaces. Yep.
The Toronto Council on Aging has a Trillium grant right now to develop age-friendly cities.
Nice.
And this is really part of it. They've done the St. Clair Young area, now they're working in Melbourne.
Okay.
So, yeah, to get a contrast of the different areas.
Is there something that we can look at in order to get more information about what they're doing?
I don't know, you can check the Toronto Council on Aging website and see
Okay.
where it's at. Yeah.
Nice, thank you. I'll check
You're
that out.
welcome.
So here's
I
where the,
should say it's a three-year study.
okay. Here's where the interval training aspect comes from. So if we think about why Canadians are not getting enough exercise, the number one self-reported reason is inadequate time. And that's true across the lifespan. So you've got Mike Evans, and I love his video, 23 and a half minutes, 23 and a half hours. He just wants the 30 minutes. We need to be thinking more and more about what can we do if we're not going to be able to convince patients that they should be exercising for 30 minutes 5 times a week. It just seems onerous. It just seems like it's too much. I'm not exactly sure. I'm not a sports psychologist, but I do know that if we can make it more approachable, they're more likely to participate. And a study out of McMaster University, Professor Jabala there was one of the first real individuals that was looking at low volume, high intensity interval training. That's a mouthful. I'll do it one more time. So low volume, they were looking at about 45 seconds of intense exercise interspersed with periods of rest. And those periods of rest were between 1.5 minutes and 2 minutes. How many of these cycles did you need to do? And both him and other studies afterwards have found that the magic number, depending on the sport and the level of exertion and the individual, around 3 or 4. So, yeah. And what happens with that? If you spike your body, if you push your body, self-reported exertion is just as effective as me quantifying based upon your VO2 max what your aerobic capacity is and then going on 80% of that. So self-reported is just as good. If you work at 80% of your maximal exertion and you do that for 45 seconds and take a 1.5 minute break, do that 4 times, we're talking about 10 minutes max. Some warm-up, some cool-down. That doesn't sound so bad.
It makes it palatable.
Do you need to have a stress test or anything before you do
Yes.
that?
There are things, you should talk to your doctor before you're starting any sort of new program. So that's true across, the American College of Sports Medicine recommends that starting at the age 35. And if there's any concerns, I always say go and chat with someone beforehand. But it's promising. And the studies aren't just simply done on college 22-year-olds that are fit. They've done it on people post-MI and cardiac rehab programs. They've done it in individuals that are at risk for osteoporosis and mild cognitive impairment. There's a large growing body of evidence, still mostly limited to people under the age of 75. We've got, as a society, a little bit of a fear of pushing that 80 or 90-year-old. And I don't know if that's actually, I don't think that that's backed with any rational fear, but there's still a cultural fear of it. And so it's hard to get REB approval, Research Ethics Board approval, to do that study looking at the older individuals. Hopefully it'll change.
I just find it very hard to find any exercise that would make me sweat and sort of the heart sort of pumping. I just don't know where to do that.
There's there's a lot of different things out there. What you've got to do is find something that you are interested in. So me telling you to do something, you're not going to stick with. You've got to find something that you enjoy yourself, either because it's something that you've done before and you like doing it, there's that social aspect to it, or it allows you to do something else like watch TV or something. But if you talk to your, maybe not necessarily always your doctor, but if you talk to friends and find out what they're doing, if you talk to a physiotherapist or an athletic coach, or if you go to the local gym or club, they might have suggestions on sports that you could participate in. And then trying stuff. It might be dance for you, It might be rowing for someone else. It could be gardening for someone else. It all depends on that individual and trying to find something that really pushes them. Gardening's probably not the best example, but dancing and rowing would be good examples there. Try a bunch of things. You might be surprised by what you like.
Well, the thing that I could think of is like kids messing around, like for 10 minutes. They do a lot of exercise, just sort of like, but you can't find that in adults.
I don't play, do they?
We don't play, yes.
You'd be surprised, I think. At the back?
You've been doing such a nice job pointing us to different articles. Have there been studies about this, like both the general and address this concept of the boredom associated with exercise? And have there been good studies, assuming we have infrastructure, like in Toronto, we got all this great infrastructure now that we're having the Pan Am Games, right? And we've got community centers all over, right? So we do have some structures there. Have there been studies that have looked at what works for mature adults?
Often, so I don't know that side of the literature very well. The sports psychology it's a growing field, quite large. I'm sure there's been some things in there, but I couldn't quote anything to you. I apologize.
There's a great book called What Makes Olga Run.
Yes.
Oh,
There's
don't
a lot
say
of people
anything else
following
yet.
her.
She
She
is
passed away
so
this year,
fun.
unfortunately, but
She's
she's a mature
She was
athlete.
95.
The title was
Oh.
What Makes Olga Run.
And she also wrote her own.
And she
Just
wrote her
after
own
the-
as well,
Yeah.
yeah. And so a lot of scientists followed her, exercise physiologists, because she's an amazing person. But it also led them to look at mature athletes, and by that, people over 80 years old, and to start studying them. So there are
Because she
actually
started
quite a
at
few studies.
65.
77.
Yeah,
Didn't she?
77.
She started doing her track stuff at 77.
But I guess I'm wondering if you weren't an athlete, which is what most of us are not, right? Then how,
Right.
like at a certain point, all of this is is very important, but if I don't know how to do sports, then it's kind of hard to say, yeah, go use that fancy center. Why would I do that? It's intimidating, even if you were an athlete.
But you're suggesting that you don't even need to go have all that fancy equipment.
You don't.
Mm.
Let's say you're walking from here to the subway stop and it's 2 kilometers away. Walk really quickly, slow down. Walk really quickly, slow down. Within that 10-minute walk, you've got yourself your own intervals, you've pushed your heart, and it hasn't changed anything about your normal routine. Some people are going to end up watching business news every morning or CBC or whatever it is. When you're watching, one of the best things that you can do is actually throw your exercise bike right in front of the television. Yeah. If it's right in front of the television, it gets really hard to ignore it. People do it.
There's also clubs, like
Yeah.
masters, games and so on. There's all sorts of levels. Like masters starts at 35 and just
For the recreational,
Yeah.
I think that's still intimidating to many. It's great for people that have that motivation, and I have a lot of respect for master athletes, but I don't think that they are something I think that we can watch and appreciate and respect, but it's not going to be what the majority of the public goes after. So I see it as, what can we do to engage most people without having to change too much of their daily routine? And so that's where the public health side to me comes into play. Most people will read Olga's story and say, oh, that's nice, good for her. Put it down and go back to their usual activities. I don't think that the majority of people will start to become engaged in track and field events because of her, unfortunately. Just like we love to watch, the number of people that watch organized sports now is higher than ever before. We love the activity of sitting and watching, not sitting and then saying, let me go out and play now afterwards.
It's demoralizing when you realize that how much you have deteriorated.
Yeah, I can appreciate that, and
I mean, it is literally demoralizing. Why should I?
Or if you injure yourself every time you try and do something, that's very demoralizing.
I like why should you continue to exercise? Because you want to go to the bathroom.
I like that.
What about those computer games like exercise built in, like Nintendo?
Like
Which
Wii
one
games,
is good to buy? I sort of wonder.
the one that you'll use.
Because
Yeah, we generally don't know what games they have, but I think that might be a good means.
If you're not someone who likes to play video games and not someone who enjoys doing the type, so they have mostly racket sports, bowling, things like
Yeah.
that, maybe some sword fighting. If those aren't the things that interest you, now that you can do it on a screen in your living room, you're still not going to be interested in it 6 months down. So you've got to pick something that you yourself are interested in. And all the master level athletes that I've ever read about, usually they're coming back to a sport or an activity that they find interesting for some reason. They might have been a runner once upon a time, or they might have enjoyed rowing, or they might have done something that had some pleasure aspect towards them. That's why they're pursuing this again. For people, I think your question was, what about us who don't really like being active, who don't like sports? Yeah, who aren't athletes, who've never really been athletes. In their circumstances, I'd say that changing small aspects of their daily life can actually really help them. If you've got, if you work in a building or if you live in a building, walk the first 4 flights of your stairs. Run up the stairs, walk the next one. Run up the stairs, walk the next one. And then get to the 4th level or 5th and take the elevator from there if you're much higher. Stuff like that can actually really help improve your cardiac fitness, give you something that's actually interval-like and not be changing much of your day and isn't a sport or activity that would be required of an athlete.
Are there classes like that are, you know, how to learn a sport? I know there's so many for children and tons and tons of commercial programs, city run.
There's different things for different groups. I know of one for people that want to get interested, that are older and want to get interested in dance. I know some things for, do we have Ainsley coming here sometime? Ainsley. She's another, just finished her master's.
Yes, she's actually working at the Alzheimer's Society.
Yeah. There are things, if you contact the Alzheimer's Society, but even if you want not, if you're not thinking I'm requiring something of that level, but I just want to, I'm a beginner that wants to learn softball, there's things like that as well. If you go through your local community club. We'll come back to this later. Ask me questions at the end if there's anything else. I just want to try to make sure we try to finish sooner rather than later. I won't be much longer. What I wanted to bring up with this slide was that this is the Canadian Physical Activity Guidelines, and here we see nice broad, to me meaningless statements of more physical activity provides greater health benefits. That's, I now understand. Those who with poor mobility should perform physical activities to enhance balance and prevent falls. That's very useful. Now I understand what I should do. I find this, to me, discouraging because I don't think that these are providing any sort of good guidelines. And I'm not satisfied with the fact that they're saying 150 minutes of moderate to vigorous intensity aerobic physical activity per week in bouts of 10 minutes or more, when there's really good evidence that you can do it in at most 10 minutes, and I have no idea where that 150 comes from. I can't find the study for that, and I find that discouraging.
Is that too low because the number is too low or too?
I think it's too high for most people. They find it sort of an artificial number out there, 30 minutes, 5 times a week. Yeah.
No, it's disappointing.
I want them to be also talking about not just what we should do, but what we shouldn't do. Just like I wish the food guide concentrated equally on what we should be eating, but also what we shouldn't be eating. And here, this is the problem. Too many people spend the rest of their day both in a chair or a bed, unfortunately. I've been in too many hospital rooms and long-term care institutions where there's actually no chairs in the bed, in the room.
Right.
There's only a bed.
Appropriate for the person in the bed.
Yes.
Get out to.
And why is that a problem? Great study out of, again, I like to try to bring a Canadian connection whenever possible. This is from Ottawa and Louisiana. Not two places that I usually think of together. But really important study looking at sitting time and mortality from all causes. And I highlighted it there. A dose-response association between sitting time and mortality from all causes. That's phenomenal. The average American, we don't have numbers for Canadians, sits for about 11 hours a day. The more you sit, the worse it can be.
Yeah.
So what should we do? If you're lying down, get gravity to fight against you. Go up and sit. If you're sitting, stand up. If you're standing, walk. Simple stuff. Olga died prematurely at the age of 95 last June.
Exactly.
But what was? Does anybody know how she passed away?
Yes, she had a blood vessel burst in her brain.
She had a brain aneurysm, and it struck on June 21st, and she passed away on June 24th. She had not seen a physician for a health issue for, I believe, 20 years prior to that. She had seen doctors and scientists, but mostly because we wanted to see her, not that she wanted to see us. And what's amazing about not just her, because she looks so sweet there, and so fierce there, is that the great thing with athletes and people that are not even at this level, she's got, 26 world records at one time, she said. Olga is in a whole different stratosphere from the rest of us. But what we do notice with people that are active throughout their lives, that are eating well, that they're able to compress the duration of disease. And I often tell, unfortunately, my patients that we're really good in medicine at extending death. I'd rather compress disease, especially disease that's going to lead towards death at the end. And I think the best thing that we can do for that, the most effective means out there, is through diet and exercise. She had lots of brain scans. Nothing could have predicted the fact that she was going to have a brain aneurysm. But when it came, she passed away 3 days later. That's not a bad way to go.
You're right. Socialization also plays a huge role.
So if we go back to that study back in 1982, the 5 things that they found that were key predictors of institutionalization, the first one, living alone. Exercise improves mood and reduces social isolation. That was the wording in that paper. Advanced age. Exercise, in my opinion, compresses disease. Requiring assistance with your instrumental activities of daily living. Exercise helps to improve executive function above and beyond other forms. If we go back to that table I had with the different cognitive domains, the one that spiked the most was at the frontal cortex of your brain, and that's executive function, and that's where you have to do things like plan. That's an important activity. Planning, predicting future events, predicting that if you step a certain way you're going to fall is an important activity. And exercise improves that capacity. Requiring a mobility aid. Protein does increase bone mineral density, and reduces fracture risk and stroke. And then mental disorientation. We know that exercise with protein helps to maintain and improve cognitive function. And that finding persists over time. So we can spend $1.5 million per day on keeping people in hospital or home care or long-term care, or we can redirect our efforts at other things that I think would be just as much more fruitful and also more appropriate to the quality of people's lives.
One thing that bothers me is when older people go into hospital and they suddenly are told that they are no longer able to go home, they swing them into an alternative level of care bed. And I experienced this with my mother when she was 96. I said, I'm going to bring her clothes in. Oh, you can't do that. We don't have time to dress her. And I said, she can dress herself. And you have a room at the end of this corridor that has empty beds and unused equipment, old equipment in it. Why don't you discard it and have a multi-purpose room? Oh, we can't do that, we don't have staff. I said, you could probably have a lot more time if you had a multi-purpose room where you had exercises, people ate together, you had programs in the afternoon. You wouldn't need all this running around because everybody would be in the same place. Nobody listens to me. This is what frustrates me about ALC beds. We could get people home again because seniors take longer for rehabilitation. Crazy.
You've got my vote.
Yeah, my mother was only 6 weeks in a nursing home, thank God.
Christopher Bill.
My problem is, I've had both knees replaced. I'm 75, and I have trouble going up and down stairs. And I know that as we get older, lifting our feet is a little more difficult. And I'd love to have a good exercise program that I could do. Like squats are hard, I can do them if I hang onto the chair, if that's okay. Is that okay to do them with hanging onto your chair?
Definitely.
Okay, because I can do squats, I can get down quite low. I've got a lot of mobility from them.
Before you even try to squat down, so before
Yeah.
you start flexing your knee, when you're brushing your teeth, hold one leg up and get used to that.
Yeah, I'm trying to do that now.
And
with
so that
balance,
actually builds
improve
strength
the
in both of
balance.
them.
Yeah. Because before I had my knees done, I went for 3 months physio and I had great quads, so I didn't need much afterwards.
Nice.
You're actually getting better after the knee surgeries.
Oh, yes.
Yep.
Oh,
A
I had
lot
them done
better.
in
So you
2006.
encourage people to
I
do
had
it
them both
early.
done at the same
Thank you for
time,
coming.
Oh, thank you so much.
under an epidural. But I was very prepared mentally and physically.
We know that knees and cataracts are the two surgeries that have the most bang for the buck in terms of overall healthcare dollars.
Exactly.
And that's exactly the reason. It improves people's mobility afterwards. So after getting a knee or a cataract surgery, you're less likely to have a fall.
Yeah.
What do you think of protein supplements as opposed to eating protein food?
I think eating food is great, but we know that your desire for food goes down with age, and your ability to consume as many calories goes down. And so if you need to find an alternative way to hit that number, and so there was, I didn't talk about it here, but the American College of Sports Medicine had a study paper back in August of 2013, and what they found was that in order to spur that anabolic drive, in a young person was, I believe, 12 or 13 grams, but in an elder, it was, depending on the individual and depending on age, between 18 and 23 grams. So you need to consume, that's a lot of protein. I don't eat meat, and so that's sometimes hard for myself and my parents, and I will give them a protein supplement. I tell my patients and my parents are wonderful people. They don't take any medications except thyroid pills, and the only pills that they take outside of that is a vitamin D supplement, omega-3, and their protein supplement. In terms of protein supplements, even for someone that are cash strapped, you can get a lot more bang for your buck in terms of buying like a whey or a protein supplement that comes from non-animal sources if you're against eating anything from an animal-derived form, and usually it's between 70 cents to $1 per 20 grams. That's cheap. And so again, from a health perspective and a public health perspective, if we want patients to get the correct amount of protein, that's an easy way to do it. Within nursing homes, they've got a price per day expenditure on how much food can cost.
Yeah,
And
not
I don't know if
much.
anyone knows the exact number. I think it's,
Hardly anything.
7-Eleven.
yeah, that's it. I was gonna say, yeah.
For a whole day.
So you can't
Per
buy a
person
lot.
per day.
Per person per day. If you want good quality food for that level, it's unfortunately very, very difficult to do. And I think that protein supplementation becomes a useful means in that argument, in that situation.
We need to relook at long-term care in a whole different way.
Oh,
Whole different way.
Get rid of it.
Yes, I feel that there are people in long-term care facilities could go home, and there are people who could go for short periods of time and back home, but we have the wrong approach. It's an either-or.
That's a whole other argument.
Yeah.
Oh, yeah.
Was there anything else? Well, thank you everyone for your time.
Thank you.
I apologize I ran a little bit late.
Maybe if you can give me the physio referral.
I'm gonna take
Sure.
her.
I'll write down, so